I have here Dr. David Balat, who also wrote a chapter in the book on direct care, and you're going to hear all about that. And it's been great to collaborate with you, David.
Likewise.
Daniel, thank you so much for having me. I felt it was important to be here and support you. This is a great effort. It's an important one. I often say when I visit with lawmakers, whether they're on the left or the right, my message is the same. We want the same thing for patients. We just have different ways of getting there. What are those areas where we can agree? And it's a difficult conversation because politics gets involved, but my hope, my goal is to focus on that patient. And that's why we want to talk about direct care models, because it truly is an opportunity to empower patients. And after all, aren't we all patients? This affects all of us. It's a human issue and not a political one. My name is David Balat. I'm the director for the Right On Healthcare Initiative with the Texas Public Policy Foundation. I'm a former hospital executive, close to 20 years. And I felt myself to being more part of the problem than the solution, which is why I got into healthcare in the first place. I really enjoyed the patient care aspect of it, and my goal was to enable those that were trained to take care of patients and give them the resources and tools that they needed to get patients healthy. So we're just not in that place anymore, and my hope is that we'll get there at some point. What is direct care? Let's move right into it. This isn't it. That's not direct care, but unfortunately that's a picture that's closer to what we have today. There are a lot of middlemen involved in healthcare. Healthcare at its most basic form is the relationship between doctor and patient. But healthcare has become more unaffordable, more inaccessible, and more inefficient because there are a lot of folks that have injected themselves between the two most important parties in that relationship, the doctor and the patient. So what should healthcare look like? How should we think about healthcare? It needs to be personal. It needs to be individual. It needs to be human. We talk about the healthcare system as if it's something sterile and mechanical, but it's your healthcare. It's intensely personal, and that's why that relationship is very important. We were greatly honored to be asked to contribute to this. I feel very strongly about direct care, and unfortunately some portions of my presentation have been I don't want to use the word stolen, but I probably stole it from them. But many of the examples I'll be using have already been used by Cynthia and Dr. Smith, and I really appreciate their work, and I'm happy to be in support of what it is that they do for the American patient. But we're going to talk about direct primary care, what it is not, direct specialty care. The specialty physicians, oftentimes people don't think that you can have that kind of relationship with a specialist. Direct surgical care, and you've just heard from Dr. Smith. Direct pharmaceutical care, this is coming on board, and it's been very interesting to see those models. And then direct dental care as well. So what is direct primary care? It's reestablishing that personal relationship between doctor and patient. But not only is it the relationship that it's establishing, it's a financial relationship as well. Because when that patient is responsible financially, it makes that personal relationship a little bit more connected. They have skin in the game. They have invested in this process, and they use it in a much different way than when the insurance company makes the payment to the physicians. The reimbursement, it's a monthly subscription for direct primary care. So think in terms of Netflix. Whether you use it or not, you could use it 24/7, or you could not use it at all, which is how sometimes I use a gym membership. But it's you have unlimited access to this doctor, but you're paying a monthly fee, and that allows them to keep their doors open and provide this service to the patients. When you think about it, I say the only because I haven't been able to find any others. It's the only reimbursement methodology that focuses on healthcare. I'm irritated sometimes when we talk about our current system. It's really not healthcare; it's sick care. Our system is reactive in nature. If you look at the ICD-9 codes and CPT codes, everything is geared towards a presenting diagnosis. Whereas direct primary care focuses on the patient. You get to ask those questions. How are you sleeping? How are things at home? Unfortunately, that's a thing of the past. With the limited amount of time that physicians have with patients, those questions don't get asked anymore. What direct primary care is not? It's not capitation, because capitation is what the insurance company paying the doctor, not the patient paying the doctor. And you don't have to go use the doctor. You can do what you want. This is a person that you've engaged with voluntarily. It's not concierge medicine. It doesn't cater to high net worth individuals. It's direct primary care has often been called blue collar medicine. They don't cherry pick healthy patients. And oftentimes the opposite is true. They're taking care of chronic patients. It's true for my father-in-law. He's a chronic pain patient, a diabetic as well. And he has a direct primary care physician, as the rest of my family does. And when he's at his end, he calls his doctor on the cell phone, and he'll say, look, this is what's going on, and how do I deal with it? And they work through an issue right then and there. So the chronic patient tends to benefit probably most. So it's the accusation of them cherry picking just doesn't hold true. And they typically don't bill third-party payers. There are exceptions. There are folks that are hybrid practices or traditional collection from insurance company and the direct primary care. Oftentimes that's so that they can transition away from a traditional practice into a DPC, but I've not seen any long-term hybrid types of practices. Typically, DPC practices have opted out of third-party payments. Patients in DPC, I pulled this off of LinkedIn, First Primary Care, and this is a review by one of their patients. And I'm not going to read the whole thing, but you all are welcome to have these slides. During this patient's first consultation, one of the first questions is, how are you sleeping, as I mentioned earlier? And he says, no doctor's ever asked me that. They normally ask why I'm there, and that was refreshing. This is affordable. This type of practice is affordable. We haven't talked about that in this country. The average range of a membership for DPC is between $60 and $80 a month. For children, it's about half of it. So it's affordable. Access, it's 24/7 access. You can get to your doctor when you need to get to your doctor, and they're typically very responsive. During COVID, I've heard stories from DPC doctors from all over the country where patient is afraid to leave their home. What happens? The doctor goes to their house because they have that relationship and they want to take care of their patient. They're doing what they went to medical school for. They're taking care of patients. And they offer personal attention. Price transparency, we've talked a lot about that. It is crucial. And I was thrilled to hear what Senator Johnson said earlier, and always glad to hear what Cynthia has to say. And then, of course, Keith supported all of that. The video that Cynthia showed had Dr. Lee Gross out of Florida. He's a DPC physician there. And he had a tweet on his Twitter account that it said a patient came to our practice in need of a PET scan. She'd been quoted $7,000. They offered a cash price of $5,000. They had a network of transparent providers. And that's another benefit of the DPC community. They will find people that are transparent in their pricing, and they'll refer to each other. Their network partner had a price of $1,600 and change. Listen to this. The savings on one test paid for nearly 4 years of primary care. That's astounding. What does that do? That empowers patients. Transparency is crucial for empowering patients. I wanted to spend a little time on this just to tell some stories. The 90% discount we heard, the $40,000 proposal or proposed price from the hospital in Georgia versus the $3,600 actual price at the Surgery Center of Oklahoma, over a 90%. And actually, it's more than that because that $40,000 really was just the hospital charge. It didn't reflect the physician, the anesthesiologist, whatever the cost of the implants might have been, radiology, pathology, who knows? Typically there's 7 or 8 bills when you have surgery. The nice thing about Surgery Center of Oklahoma is that price is one price. It's a bundled price. It includes all of those professionals. So that price you get is the price that you'll pay, end of story. The $74,000 savings, it really wasn't a $74,000 savings. It was this was a patient that I was helping. I do participate in some patient advocacy work. And she needed a very specific type of surgery. And she went to a hospital in the Texas Medical Center. They quoted her, the price was $74,000. They were giving her a cash discount because she was a member of a sharing ministry. So they said they would give her a discount down to $36,000. Well, the sharing ministry was only going to cover $23,000, which was 170% of the Medicare rate. And the hospital said, well, no, we wish you well. They weren't going to take it. And she couldn't afford the difference. It was more than she could afford. So I called our friends at the Texas Free Market Surgery Center in Austin. And I said, Sean, this is the surgery that she needs. She's willing to come. Can you perform it? He says, we don't perform that surgery, but let me see if I can find the resources, the physician, the robot, all the things necessary. He called back 3 days later and he said, I can do it. And our price is $21,000. So she had a $0 out of pocket. The sharing ministry covered 100%. The next example was another patient that I had. She had five prescription medications. And all combined, she was paying $500 a month. We got that down to less than $20 for all 5 of them, using various discounts and cash pay options. She had just about a $6,000 annual savings ongoing because these were medications that she was going to have to need regularly. Ear tube removals. I had some folks from Houston that I knew very well. Their kid needed to have their ear tubes removed. Everybody's had somebody that they've known that's had to have that done. And the average price that they found, they had a $5,000 deductible, and the average price that they found regularly was between $5,000 and $6,000. So it was going to eat up 100% of their deductible. They were looking for other options. They'd seen some of the things that I've written, and they looked at Surgery Center of Oklahoma. And this is what it looks like. You can actually go to their site, pick the surgery that you're interested in, and as you'll see there, ear tube removal is $1,500. That's an all-in price. They flew to Oklahoma, got a hotel, spent a little time as a family, had the procedure, came back to Houston, and they were well below that $5,000. So they had a little family trip as well. And they had a great outcome. This has been said throughout this presentation, and I loved hearing it from Senator Johnson as well. We have a broken third-party payer system. That's the principal component of what makes it broken. When we hear many politicians talk about healthcare, they're not talking about healthcare. They're talking about health insurance. Coverage does not equal care. And I would love for us to start having a conversation about how to deliver care to patients. We could do it for much less than what we're spending today in providing access. The ACA increased access, but it didn't improve care. We're seeing we're seeing worse mortality rates, and we're seeing folks that are having to go to the ER as opposed to seeing a physician. And you don't want to get your primary care in an emergency room. I can assure you that as a former hospital CEO. With that, Daniel, I'll take questions.
Thank you very much. That was really informative, and it's making me wonder, as a employee with very generous insurance benefits, I could maybe even save money by going to direct primary care. But I had a few questions just from an economic standpoint. First of all, what are the scale parameters for an individual physician in a direct primary care setting. So in other words, what's the minimum number of patients that to make it viable? What would be the maximum number so it's not to overburden?
That really depends on the physician. I've seen ranges between 600 and 800 patients per physician. They also have nurse practitioners that function as extenders if they need to increase that pool. But it's very important that they're able to spend the time with those patients. But that's something that we can really expand throughout the country. Many physicians have gone into specialty care because primary care just is too much of a hassle, and it's too expensive because 40% of their overhead goes towards collecting from insurance companies the reimbursement for the services they've already rendered, and they make it inordinately difficult to do that.
Okay, so the other question was, in terms of dealing with maybe patients with chronic conditions or patients who are just more needy in terms of services, what you seem to describe as a flat rate environment. And I'm wondering if a flat rate environment is going to work in terms of preventing the chronic need patients from just kind of overwhelming the services of the physicians. So in other words, does there need to be some kind of price differentials within the direct primary care?
No, there's no actuarial work when it comes to DPC. They're not a form of insurance. There is a price differential as it pertains to age, the age bracket. So, but whether you're chronic or healthy, they're going to charge you the same price if you're within an age range. Very welcome. I'll let you drive that. Can you just got? Sure, you can read the question. Certainly. Yep, forgive me, I didn't bring my reading glasses. Can you discuss some of the recent proposed legislation about DPC? What was good about it? What was bad about it? Ah, thank you, Shannon. The president actually had an executive order related to HSAs and increasing the number of qualified medical expenses. Today, you cannot use HSA dollars for a direct primary care membership because the IRS is trying to take the standpoint that DPC is another form of insurance and therefore invalidates their ability to use HSAs, because if you have a high deductible health plan and you have DPC, which they consider a second insurance, then you can't use those HSA dollars. The president's executive order, it went to Treasury. Treasury has just come back out with their proposed rules, and the comment period ends on August 10th. They still have it wrong, but we are working with a broad network to inundate them with comments so that they can understand what direct primary care is and what the proper role of different cost sharing organizations and sharing ministries are, so that HSA dollars could be used for that. Health savings accounts should be used by patients for the care that they choose to participate in, and not as dictated by the government.
So to clarify, some of the opposition to that is from the insurance industry?
You know, it's a mixed bag from the insurance companies. There's opposition from Treasury, from government. There's some opposition, a lot of opposition from the hospitals, because they don't have as much control over those primary care physicians. And from my perspective, having been in the hospitals, your primary care doctors are really worth their weight in gold, because that's where a lot of your surgical referrals come from. Yeah. And if you've lost control, if the hospitals have lost control, it's a problem for them. They make most of their money in the OR.
Right. Yeah. Okay. Well, thanks, David.
My pleasure.
It.
Thank you.